Good afternoon. Today we will discuss about irritable bowel syndrome. Irritable bowel syndrome is a chronic functional disorder manifested by alteration in bowel habits and recurrent abdominal pain and bloating. IBS is a symptom complex influenced by a variety of physiological determinants from gut to brain and back. So for the diagnosis of IBS, we have Rome 4 criteria for the diagnosis of IBS. The criteria is patient has recurrent abdominal pain more than 1 day per week on average in the previous 3 months with the onset more than 6 months before diagnosis. So and abdominal pain is associated with at least two of the following symptoms. So pain related to defecation and change in frequency of stool and change in form appearance of stool. So patient has none of the following warning signs: the age more than 50 years, no previous colon cancer screening and presence of symptoms. This is the Roman 4 criteria for diagnosis of. And let's coming to the physical findings and clinical presentation. The clinical presentation of IBS consists of abdominal pain and abnormalities of defecation, which may include loose stools, usually after meals and in the morning, alternating with episodes of constipation. So physical examination is generally normal and non-specific abdominal tenderness is generally present, may be present. So causes of irritable bowel syndrome. So first, the cause is exactly unknown. It is believed to be multifactorial disease. The associated pathophysiology includes altered GI motility, alteration in gut flora, and increased gut sensitivity. So risk factors include anxiety, depression, personality disorders, history of childhood abuse and sexual abuse, and domestic abuse in women. Coming to the differential diagnosis. So differential diagnosis is inflammatory bowel disease, diverticulitis, colon malignancy, endometriosis, peptic ulcer disease, biliary liver disease, chronic pancreatitis, and constipation caused by medications, diarrhea caused by medications, small bowel overgrowth, celiac diseases, parasites, lymphoma of GI tract, and pelvic floor dyssynergia. So how to work up the cases of C? So it is important to identify red flags of the other diseases such as weight loss, rectal bleeding, and onset in patients more than 50 years of age, fever, nocturnal pain, family history of malignancy or IBD. So additional red flags include abnormal examination, examples mass, enlarged lymph nodes, stool positive for occult blood, and muscle wasting, and abnormal laboratory values of anemia, leukocytosis, and abnormal chemistry. So laboratory test, blood or CBC test is generally normal. CBC is reasonable to evaluate for anemia. The presence of anemia should alter to the possibility of colon malignancy or IBD. Other reasonable tests include C-reactive protein, tissue transglutaminase antibody, and TSH. And testing for stool for ova and parasites should be considered only in the patients with chronic diarrhea. Evaluation of stool for Clostridium may be helpful in patients with predominant diarrhea symptoms who have recently taken antibiotics. And fecal calprotectin level is useful to differentiate IBS from inflammatory bowel disease in patients who have IBS with diarrhea or with both diarrhea and constipation. Imaging studies. The imaging studies include sonogram or CT of abdomen and pelvis. Lower endoscopy is generally normal except for the presence of small spasms. Colonoscopic imaging should be performed only in persons who have alarm features to rule out organic disease and in persons older than 50 years to screen for colorectal cancer. So non-pharmaceutical therapy. So the patient should be encouraged to maintain an adequate fiber intake and to eliminate foods that aggravate symptoms. Avoidance of caffeine, dairy products, fatty foods, dietary excesses is also helpful. Several clinical trials have shown that a diet low in fermentable oligosaccharides, disaccharides, and monosaccharides improves symptoms in nearly 70% of the patients. And cognitive behavioral therapy is also recommended, particularly in younger patients who faces lot of stress and these stress triggers the IBS. In general, RX, the mainstay of the treatment of IBS is a high fiber diet. Fiber is helpful for relief of constipation but not for relief of pain. Because symptoms are chronic, the use of laxatives should generally be avoided. Soluble fiber is more effective in symptom relief than insoluble fiber. So patients should be instructed that there might be some increased bloating on initiation of fiber supplementation, which should resolve within 2 to 3 weeks. It is important that patient take these fiber products on a regular basis and not only as needed. So considerations: some patients with IBC but without celiac disease show symptom improvement on a wheat free diet. A 2 to 3 week trial of wheat avoidance may be reasonable in patients with treatment resistance IBS. Patients should be educated regarding maintenance of high fiber diet and elimination of stress factors, which can precipitate attacks of IBS. So, they should be reassured that their conditions does not lead to cancer. And conclusion: more than 60% of the patients respond successfully to treatment over the initial 12 months. However, IBS is a chronic relapsing condition that requires prolonged therapy. Thank you.